You are listening to the PRS Journal Club podcast with your hosts, Drs. Jordan Frey, Chad Purnell, and Dr. Shuja Shafqat.
Hi everyone, welcome to the November 2017 special Masters edition of the PRS Journal Club podcast. My name is Jordan Frey, PRS Resident Ambassador from NYU, and as always I'm joined by my co-resident ambassador Shuja Shafqat from Fox Chase Cancer Center and Chad Purnell from Northwestern. So today we have the honor of being joined by Dr. David Chang, Professor of Surgery and the new Chief of the Section of Plastic and Reconstructive Surgery at the University of Chicago. Thank you very much, Dr. Chang, for joining us for this special Masters of Plastic Surgery edition of PRS Journal Club podcast with a focus on reconstructive surgery.
Happy to be here. Thank you for inviting me.
So the article we'll now be discussing is entitled, Not All Gustilo 3B Fractures Are Created Equal, Arterial Injury Impacts Limb Salvage Outcomes. This is an article from NYU by Dr. Stranix, Lee, Jacoby, Anzai, Avraham, Thanik, Sadeh, and the senior author is Dr. Jamie Levine. And as a reminder to everyone, all of this month's articles can be read for free on prsjournal.com, including an archive of all past Journal Club articles. So, in ways of an introduction, we know microsurgical free tissue transfer has revolutionized the management of severe lower extremity trauma and really become the standard of care for open fractures with significant soft tissue injury. And a key component of all lower extremity microsurgical reconstruction is identifying healthy tissue and vessels outside of the zone of injury. That's really the key component. And preoperative identification of arterial injury and any pre-existing vascular disease can help facilitate the design and execution of these complex reconstructions. And in his classification of open tibia-fibula fractures, Gustilo recognized that ischemic limbs, which were designated grade 3C injury, had the worst prognosis. However, his classification does not take into account patients with arterial injuries that otherwise have a non-threatened limb, so this would fall into the 3B grade. So the authors therefore sought to identify patients with Gustilo type 3 injuries who underwent soft tissue free flap coverage and examine the impact of arterial injury in outcomes. And so to do this, they identified all Gustilo type 3 open tibia fractures that underwent soft tissue free flap coverage over a 40-year period. They excluded vascularized bone flaps, any injuries above the knee or below the ankle, and patients with incomplete records. They reviewed demographics, operative variables. Specifically, they defined arterial injury as a disruption of continuous flow on a preoperative angiogram or intraoperative identification of significant arterial trauma, and they examined their outcomes with regards to these variables. So ultimately, they identified 361 patients. The majority, 92%, had Gustilo 3B injuries, while the remaining 8% had 3C injuries. In these preoperative angiography, they identified 126 that had an arterial injury, with an additional 27 found intraoperatively. So out of the 361 patients, 42% had arterial injuries, with injuries to the AT vessel being most common, followed by perineal and PT. They review a lot of data with regards to types of flaps and operative variables, and I'll try to hit the salient points. Muscle flaps were most common at 80%. They broke down the timing from injury to coverage, and they found that timing was not found to be significant or demonstrate a significant cutoff or window period associated with increased complications. And importantly, they identified that the presence of any arterial injury, even when that artery is not used as a free flap recipient, was associated with significantly higher flap complication rates, specifically when the PT was that injured vessel. And this was borne true on regression analysis. And they found that as the number of patent arteries in the leg decreased from 3 to 2 to 1, the risk of complications, takebacks, and flap failures increased. So in their discussion of these findings, the authors note specifically that this study built on the legacy of Dr. William Shaw, who started this database at Bellevue Hospital in 1979, and they've accumulated obviously a great experience in lower extremity trauma, and they've identified arterial injury as a surrogate indicator of patients with greater destructive force, with more severe soft tissue injury, and higher rates of complications requiring larger flap sizes. And they note specifically that the Gustilo classification, which was traditionally used in describing these lower extremity injuries, was really an orthopedic system that was designed with microsurgery in its infancy and was not necessarily designed to guide reconstructive efforts. And it doesn't account for the presence of arterial injury in a non-ischemic or an otherwise perfused limb. And obviously this results in significant heterogeneity among these injuries. So what the authors recommend is a modification of the 3B classification, which is basically a 3-2-1 modification where that number indicates the number of vessel runoff that limb has. And they posit that this is a prognostic value and also has clinical implications with regard to recipient vessel selection as well as anastomotic technique. So overall, I think this is an interesting article and provides some useful clinical information. I think that most of us could intuit that diminished vascularity of the lower extremity would increase complications with limb salvage, but this study proves it and also provides some prognostic information and some considerations that will go into the reconstruction. And perhaps most importantly, this is really a kind of a simple modification to the classification system that we're already using, the 3-2-1 modification, and so it's sort of easily incorporated. So Dr. Chang, I'm interested to hear your thoughts about this paper and specifically if you feel this correlated with what you found in your experience and if you would potentially incorporate this modification into your assessment of these injuries.
This is a very comprehensive paper that spans over like 37 years, a very long time. So, really kudos to the authors for getting this data together. Certainly, I think the one thing that maybe was overlooked at the damage to the arterial system in legs, even though it was not causing ischemic injury, the significance of it. And it doesn't make sense that if the injury was significant enough to cause that much of arterial damage, the nature of the injury may have been much more severe, leading to more complications. So I think maybe modifying this classification might be useful. I would say that damage to the venous system might be just as significant, but because only the pre-op angiography were done routinely, we have information about the arterial damage, but there really may not be, I don't know if they really looked at the evaluated venous system as well. So there's a lot more things that we didn't study during this time. So, over 37 years, a lot has changed in the way we manage the lower extremity open tip fit fracture. For example, timing. Initially, it was recommended to perform the reconstruction acutely. Now that we know that as long as you do adequate debridement, the timing is not as important. Whether you should use a muscle flap versus a fascia cutaneous flap. A lot of people think that the muscle flap is much better, but now there are some evidence to show perhaps it's not necessarily true. Maybe fascia cutaneous flap is just as good. And now with also the introduction of the wound vac really has changed how we treat lower extremity trauma. And now you're able to put a wound vac on it and then come back later and do a delayed reconstruction. And then using also the retrograde flow vessels as recipient vessels. So a lot has changed. All the approaches have changed, and over 37 years, I'm sure at NYU, this probably involved numerous number of attendings, residents who do things a little bit differently. And so there's a lot of variables here. But the important thing is that I think this paper does bring up some important information that are useful. And I think it helps us to evaluate how we've been managing the lower extremity trauma and looking at the arterial damage, maybe even venous damage, and all the other factors. And I think this was a well-done study.
Thanks, Dr. Chang. I think those are a lot of really important points. And I think especially, probably Chad, Shuja, and I really take for granted the wound vac and all that can kind of afford, because I certainly know rotating at Bellevue, there's a lot of nights where there's multiple lower extremity traumas coming in, and the orthopedic service is able to kind of wash them out and put a vac on. We can sort of temporize things and prioritize to get to everyone. So, Shuja, what did you think of this paper?
Thanks, Jordan. So I agree. I thought it was a really good paper, well-researched, a lot of patients over a long period of time. Certainly studying, 300 free flaps for lower extremity trauma reconstruction is a feat, and the author should be congratulated for this, like Dr. Chang mentioned. You also mentioned that, timing of flap coverage. I found it interesting in this paper that the timing didn't necessarily impact complications, which is kind of contradictory to the traditional teaching, though, some of the evidence hasn't borne that out. One thing I thought that was really great is that, we're taught this Gustilo classification. It's on every in-service exam. We learn it over and over again, but it didn't really help us look at outcomes per se. Not every grade 3B injury, as this paper says, is the same. And so I think it's a really good update because it gives us something that's a little bit more prognostic with this classification system that we all know and we use to talk to each other and we use to write about these things. Whereas some of the lesser known classification systems that did look at energy of the injury as being more prognostic, some of those classification systems don't come up as much. So I thought that this was a really great update to that, and I think it was a really good paper. I actually wanted to ask a question for Dr. Chang about venous anastomosis. You did mention a little bit about the venous injury. The authors did mention in the study about a possible protective effect of doing 2 venous anastomoses, but they don't really elaborate on the paper. There's a lot of conflicting evidence about, is 2 venous anastomoses better? Is 1 venous anastomosis better? I wanted to ask what your opinion on that was, and if you're doing lower extremity reconstruction, especially, do you prefer primary anastomosis to the superficial or deep system? And then what about your second anastomosis if you're doing 2?
The 1 versus 2 that have been controversial for a long time, and some people think the more the better. There are those who think that doing 1 is actually better because when you do more than 1, you reduce the venous flow to each anastomosis and actually increasing the chance of those vessels becoming thrombotic. I'm a 1 vein person. I usually just do 1 vein. I would say over 90% of the time, whether I'm doing a lower extremity or head and neck or breast, I usually just do 1. Now, having said that, if I feel that 1 vein somehow I don't really feel good about it, then I may do a second one, especially if there's a recipient vein right next to it. So especially now with coupler, it doesn't take very long to just put the other one on. But for the most part, I'm a 1 vein person. And I think many studies have compared this, and conclusions have been conflicting. Some have said there's no difference, and some have said that the 2 vein is better. I would say that there is no answer either way. In terms of a deep versus a superficial system, I generally prefer deep system over superficial. Again, I think because superficial systems are more prone to going into spasm and maybe are more prone to being injured and compressed. But in patients with lower extremity trauma, you have to see how the deep venous pressure is. So if there was a lot of crush injury and if the deep system has a venous hypertension, then obviously that you want to avoid that. But for the most part, if there is no deep venous hypertension in the deep system, I generally prefer deep system. For example, I prefer to use the VC as a recipient vessel compared to saphenous vessels. And even for the flap, whether, for example, when doing a radial forearm flap, I'd rather use a VC as the donor vein rather than a cephalic vein. I prefer to use the deep system when everything being equal. So that's my personal preference.
Great, thank you. Chad, what did you think of this article?
I really enjoyed this article. I think just like you said, Shuja, we learn this classification, but whenever you get out into the real world and we're seeing these patients, well, we're doing free flaps for a lot of patients with a 3B, but some of these patients go on to do well and others don't. And I think this paper really does a good job of at least beginning to answer who are these patients who tend not to do well, or at least their flaps tend not to do well, and which patients do their flaps tend to do better. And so I really enjoyed it. I think this is something that I'm definitely going to be looking for the next time that I see a patient with this type of injury. And I'm going to be looking to say, hey, what kind of runoff do they have? And how is that going to affect their prognosis? And so I think it was a really kind of immediately useful article. Dr. Chang, what I wanted to ask you was, obviously, as plastic surgeons, our goal is to, if we're given a defect, we want to reconstruct that defect. But a certain percentage of patients are going to do better, or at least go on to have an amputation whenever they have a lower extremity trauma. And so it seems like some of the old indications for an amputation are being challenged. Like, for example, there are groups saying that, well, if you have a tibial nerve transection, maybe you should try and reconstruct the nerve and you should still try and do limb salvage. Dr. Chang, I wanted to know, what are your personal indications for referring a patient for amputation?
Yeah, when I trained and we followed those rules you mentioned, if there's major nerve damage or if the limb is going to be insensate, the amputation would be better, especially if it's below the knee. And patients do very well with the amputation and with the rehab, and recovery is much faster. But as you mentioned, the pendulum is somewhat changing, and people feel that we should try to reconstruct as much as possible, even when there's nerve damage, and not just for the purpose of function, but even for the psychological, emotional impact. So I think these are all very good discussions to have. But I tell you though, now there has been a lot of advances being made with prosthesis, as you know. There are TMRs and robotics, and some of the prostheses are very advanced. And I think that with the improvement in technology, we will see even better prostheses. So while technically and surgically we could replant and reconstruct any limb, whether it's lower or upper, there might come a day where the prostheses are so much better functionally, maybe even aesthetically look better, that it will be the best option, clearly, compared to some of the poorly performed reconstruction. Because certainly, you can put the limbs together and reconstruct it, but if it doesn't function well, and if it's causing pain, infection, develops osteomyelitis, and all those problems, it certainly can be more of a detriment to the patient than a benefit. But these are all good questions to address.
Great, thanks a lot. Sometimes looking at these things, there are more questions raised than answers, and I think limb amputation after trauma is definitely a changing field for sure. Jordan, I'll kick it back to you for the wrap up.
Yeah, I think those are all great points and really a fantastic discussion overall. I think especially the last points we hit on very important in selecting patients, and especially kind of hits on the patient expectations and education, and really talking to them about what they can expect and doing what's best for each patient. But I think with that, we'll end our discussion of this article. And again, as a reminder to everyone, remember to tune in to the other 2 articles we'll be discussing on this month's podcast, as well as all our previous and future podcasts, which we broadcast every month. And don't forget to participate in our monthly hashtag PRS Journal Club on Twitter or Facebook, where we'll be able to interact directly with this month's selected article's authors. And once again, thank you very much, Dr. Chang, for joining us for this Masters in Plastic Surgery Journal Club podcast.
Thank you.